The next session is much, much more immediate, much greater concern, and it's the issue that we all know about. It's the issue of perhaps undocumented children, migrant children. But we're right in the middle of a huge controversy, but a controversy that's not just an academic debate. It's having consequences in the lives of mothers and children every day. And so this discussion, we've got two speakers to take us through. We've changed the order in which they're going to present. So the first speaker is going to be Dr. Stevenson, and then we're going to be followed up with Professor Vearey. So let me start off by introducing Sasha. Again, she's someone who would be familiar to many members of this audience because she has been part of our conferences before. But Sasha is a South African human rights lawyer, but she's also the executive director of Section 27. And I think everybody must have heard about Section 27. If you haven't, it's a public interest law center. And so she's worked over more than a decade to secure systemic change in health and education. She's used with Section 27 litigation. There's been advocacy efforts, but it's all about constitutional rights and how to advance them. And so in her career, she's represented families in the Life Esidimeni arbitration, and also more recently during COVID-19 to ensure that school feeding programs were continued. So Sasha, we're delighted that you're joining us this morning, and please go ahead.
Thanks, Harun, and lovely to be here. So I was asked to speak about responding to Operation Dudula and the violation of children's rights. But of course, Operation Dudula is one actor in a health xenophobia ecosystem, unfortunately, and the fight against health xenophobia is much longer than the life of Operation Dudula, but it has changed in recent years. So whereas previously we had to contend with health workers, other staff at facilities, hospital leadership, unfortunately also provincial and national leadership who were trying to turn people away from accessing services, we're now also having to deal with vigilantes at the gates and sometimes inside the clinics, as well as having to deal with those whose direct work and constitutional obligation is to ensure access to services. And this is all in a context where the law on children's access to health is actually pretty clear. The Constitution, as you all know, provides explicitly that children have a right to basic healthcare services and that the child's best interests are paramount in any matter concerning the child. The National Health Act then also provides that the state and facilities funded by the state must provide free healthcare services to children under 6. And for children who are over 6, there are various other protections which should secure PHC services for children and hospital access for at least refugees and asylum seekers and undocumented migrants from SADC states, and certainly also for their children. Of course, we know that the law hasn't always been complied with, and for about 10 years at Section 27, we were getting case-by-case referrals of people coming to us and saying they've been turned away. And over that 10 years, we would write to the hospital, say these are your legal obligations, and that mother and child would be admitted. And so that continued for 10 years, where the law was clear, it wasn't being implemented properly, but we were able to get it implemented on a case-by-case basis. But of course, a lot of people never knew about us and didn't get to us and weren't able to access services through our intervention or other people's intervention. But then in 20, I think it was 2020 or 2021, Gauteng Health changed its policy contrary to the law. It directly restricted access. And so we then went to court to directly challenge this change. And we got a court order in 2023 that confirmed the law as it relates to children under 6 and pregnant and lactating women. It required that the policy of the Gauteng Department of Health was changed. And it ordered, importantly, that circulars must be circulated around hospitals and clinics, and that posters must be stuck up in hospitals so that everybody would know what their rights were. And for almost a year, this seemed to solve the bulk of the problem. And then we saw that, the complaints that came to Section 27's advice office were right down. It really did seem to resolve much of the issue. But then Operation Dudula appeared in 2023, or thereabouts, and they had a brief, if violent, run in relation to health by blocking migrants from accessing services. And so then Kopanang Against Xenophobia approached the court, represented by Socioeconomic Rights Institute, to interdict Operation Dudula from blocking access to healthcare services, amongst all of the other things they were doing, including acting as immigration officials, requiring people's documents, taking violent action. And there was a very slow court process that meant that it was mid-2025 by the time the case was heard, and late 2025, late this year, before an interdict was awarded by the court. And the interdict that was awarded by the court prevented Operation Dudula from blocking access to healthcare facilities. And it also required various other things from Operation Dudula and various state actors. But unfortunately, the case, far from preventing the action of Operation Dudula, seems to have reinvigorated them. And they then seem to turn the bulk of their focus to health facilities. We've also got to note that it's not just Operation Dudula as much as they are the main name that gets used. March and March is another group that cropped up mostly in KZN, also in Gauteng. Patriotic Alliance and Action SA have all also been involved in this xenophobic campaign. And while Operation Dudula has said that they're appealing the case that interdicts them from blocking access, they haven't actually done anything, as far as I know, to interdict that case. And instead, they seem to be willfully violating the court order so far without consequences. And the effect, as Haroon says, and as many of you will know, is that many children and their parents have been blocked from accessing healthcare services. ARVs aren't being dispensed, antenatal checkups have been missed, and sick children haven't been able to get care. There have been women in labor who have struggled to get access to the services that they need. And as a result of all of this, a few things happened. From government, unfortunately, we saw almost nothing, in this province at least. In KZN, there was some movement in the right direction. In Gauteng, very little. There was a statement from the Minister of Health that discouraged vigilantes after he met with Operation Dudula. But it was discouraging vigilantes largely on the basis that undocumented people could also be South Africans, which is of course true, but it's really not the point. There was even more silence from provincial health in this province. We just didn't see leadership from our leaders. From healthcare workers, it's really been a mixed bag. Many healthcare workers have done a huge amount to assist people to access the care that they need, including vaccinating children through fences, out of sight of the self-appointed guards at the gate. Health workers have arranged to meet patients outside of clinics, and they've snuck people into health facilities. Unfortunately, other health workers have collaborated with the vigilantes. They've let them into clinics. There are a lot of people who are operating from inside of clinics, handling patient files, often given to them by healthcare workers, and notifying the people at the gate, the self-appointed guards, of foreign patients, and clearing out facilities as a result of this. So some of what we've seen from health workers has been heroic and has been caring, and some of it has been utterly disgraceful. From the civil society side, there's been quite a lot of action. Health rights civil society sprung into action, trying to get leadership from our leaders, asking people like the minister, the provincial leadership, the Human Rights Commission, to make statements and take action to prevent this from continuing. Many within civil society have also been assisting individuals to get access to care, including working with Uber drivers, for example, to pretend to be the husband of a pregnant woman and drive them into the health facility so that they are able to get the services that they need. So there have been a lot of unsung heroes in this time. But of course, the problem still continues. Section 27 received over 200 calls from migrants in the last couple of months, and we've assisted the majority of them, directing them to accessible facilities, helping them get in. MSF has set up a hotline and has provided basic services almost as in parallel to the health system. And the TAC and Kopanang Against Xenophobia have helped hundreds of people into care. But all of this individual action has not prevented the systemic problem, which is that there are still vigilantes at the gates and in some cases in facilities. And the people who are responsible for ensuring access to healthcare services, those people being government, that's responsible constitutionally for providing access to healthcare services, are not removing the barriers to care. And those barriers, in this case, are vigilantes. And so as a result of that, a couple of months ago, we launched litigation against Yeovil and Rosettenville clinics, the city of Joburg that runs those clinics, and the Minister of Health and the Gauteng MEC, as well as against the police. And we were acting on behalf of the TAC, MSF, and Kopanang against xenophobia. So there's cases in two parts. The first part relates just to Yeovil and Rosettenville clinics that were really hotspots when it comes to this vigilante action. And the second part relates to all health facilities. And essentially what the case is trying to do is to ensure that the government entities responsible for ensuring access to healthcare services take the steps that are needed to remove barriers to care, like vigilantes, and to then report incidents to the police, who must then act on those reports. So what we're essentially saying is that there are obligations on health leadership to do what they can to ensure access. And access doesn't just mean making sure the clinic is there and there are drugs in the clinic, but it's making sure that barriers are removed. That then where there is intervention, particularly violent intervention, the police must be called. And then there's a request for an order against the police that they must take action because they haven't been taking action in the months that have been passed. So this case was heard on Tuesday in the Gauteng High Court, and we're expecting a judgment as early as next week. The judge has said we should expect a judgment then. And what I hope that the judgment will make clear is that not only do vigilantes themselves have a duty not to prevent access to care, but government has a responsibility to ensure access to care. And this obviously means preventing people from taking it upon themselves to so-called police publicly funded health facilities. If we win, and I think we will, government will have to start doing its job in this regard. The problem is then we just return to the previous version of health xenophobia, the one that comes from inside of health facilities. Operation Dudula hasn't gone away, despite it being interdicted, despite this new case, which wasn't against Operation Dudula itself, but certainly concerned them. It's carrying on its activities at health facilities. Its funding is clearly continuing. There's no way people are volunteering to sit outside clinics and turn people away for 8 hours a day. So there is somebody who is funding and orchestrating this work. And my fear is not the organization itself, but that Operation Dudula and friends have illustrated the depth of xenophobia and potentially the limited utility of the law. We're just still not seeing leadership from the people who should be standing up for constitutional rights. And in my view, it's going to take South Africans, whether health workers or community members, other leaders, to mobilize against xenophobia and health xenophobia if we're going to counter it, because otherwise we risk legal whack-a-mole with growing support for anti-migrant movements, and that's only going to move us in one direction. Thanks, Haroon.
Thank you, Sasha. That was extremely clear, concise, and I think everyone who's heard you now have a very clear idea of all the processes involved and all the actions. We are going to have a panel discussion, so at this stage I won't ask any specific questions. I think we'll let Professor Vearey go first, and then we'll hopefully have at least 20 minutes to discuss the issues. And I suspect there'll be lots of views. I'm actually going to open up for people to ask questions using your mic rather than just through the chat. So let me then now introduce then Professor Jo Vearey. I hope I get your surname right. I wasn't quite sure how to pronounce it,
that's
Jo.
perfect.
Thank you. But Jo is an associate professor at Wits University. She directs the African Center for Migration and Society. And so not surprisingly, she specializes in migration and health. And she's an internationally recognized expert in global health and migration. So again, delighted that you were able to take up our invitation, Jo. And the title we've given you to talk to is the idea of invisible at the clinic. But I think you'll take us through the detail of what invisibility means. Thank you.
Sure. Thanks so much, Haroon and colleagues. And I think thank you for putting this session onto your program. As Haroon said, it is something we're all familiar with in different ways. And Sasha, thank you so much for giving us such a good, solid overview of many of the challenges that are faced, particularly in the South African context, and the ways in which these are pervasive. And it's not new and it's not going away. And I just really want to emphasize that point that Sasha was making. Organizations like Dudula and March to March are organized. There is somewhere along the line a professional organizing structure. And as Sasha says, there's money. And we need to be aware of this, and we need to be aware that there are threats to next move to schools and be trying to police child access into primary schools, for example. We need to be aware that there are these bigger plans, and we need far more intervention from the state. Conversations I've had with colleagues in the National Department have also shared their own challenges around where does the rule of law sit? Where do we sit in terms of the responsibilities of the department versus the responsibilities, for example, of police? And again, that adds to this sort of melting pot of different forms of chaos when we're looking at governance. And really recognizing that if we're not able to police and manage and stop these kinds of activities, this isn't only affecting people who were born in countries outside of South Africa, it's affecting everyone reliant on the public healthcare system. So regardless of somebody's personal opinions on immigration and the rights of individuals in the country, the recognition that by addressing and presenting challenges to a small number of foreign nationals is actually hurting the society at large is a key message we need to get across. So what I want to do in the next sort of 15, 20 minutes is take you through some kind of key insights into work that our centre's been involved in over the last sort of 10, 15 years, but trying to tie it to what Sasha has been speaking about. And I think for many people in the conference, many of you are involved in research, and the challenges that we face in how do we translate research into action? How do we work with colleagues working in advocacy sectors to use research findings to support the arguments they're making whilst retaining, and I think this is an important challenge when we're thinking about the kind of terrain we work in, the academic independence that's important to justify the rigor of research, but translating it to be used in multiple ways, whether that's working with key state actors or working with advocacy groups. How can we strengthen that relationship? So I wanted to start with something that I think isn't unfamiliar to people. Madeleine Cronje is a photojournalist, and she did some work a couple of years ago working with different migrant women, in this case, women predominantly from Zimbabwe and the DRC. Janet isn't this lady's real name, but she gave permission for her face to be used. And her baby died shortly after she'd given birth at a state hospital, which won't be named. And she was explaining to Madeleine how this was due to a refusal to help her. And unfortunately, this is a situation that we hear far too often about the ways in which individuals are profiled based on the language they speak, the clothes that they wear, or just simply how somebody is perceived to look. There's a profiling that takes place as somebody begins to enter a facility. And we've done work that shows this starts at the level of the security guard outside the clinic or outside the hospital when people are asking for directions or assistance, and really seeing where that issue around refusal and refusal to help, how pervasive that is throughout the whole system. I do think it's important to flag that I believe the South African public healthcare system and healthcare workers present a very different challenge to what we see in other countries globally. In many countries, we see that healthcare workers really stand by the importance of the need to provide care to everyone and will stand up for the rights of underserved and marginalized groups. Unfortunately, in South Africa, we don't always see that. And as Sasha has said, we do clearly see times where healthcare workers are themselves complicit with issues around anti-foreigner sentiment and refusal of access. But it's important to recognize we know that isn't everybody in the system. And we know there are many reasons that this sort of xenophobia is taking place. And it's not simply linked to somebody being a foreign national. We know that there are various challenges and frustrations faced on the front line, but we need to be addressing those. We're also aware that those who are working at the very, very front line, so your receptionists and clerks, for example, are often where the level of refusal and denial of access takes place. Once somebody actually gets to the level of care and meeting a provider, then we often see a different experience. might not be denied care completely, but have a difficult experience, but it's getting through those first barriers that are seen to be key. This refers to some of the work that Sasha was talking to. There's a drafted information pamphlet that's about to be released through the Collective Voices Collective. And just to say that this is really an updated piece of information that is for supporting not only foreign nationals in understanding their right to healthcare, but also for supporting healthcare providers in understanding those rights as well. And really providing things like a flowchart to show how somebody should be able to access care and where their rights to access care sit. So one thing that I think is important, and this is probably my perspective more from the research side, is I want to be able to convince all of you who might not yet be convinced why migration and health is such a key issue. It is a global health priority. It is a public health priority within the South and Southern African context. And it's one that unfortunately still remains marginalized. And this obviously is affecting negatively the health of everybody who moves, including children, including mothers, including fathers, but it's also affecting the health of those who are living and working in these spaces as well, where we're seeing challenges and barriers to access to care. So we can talk about 4 key components here. The first, thinking about the health of individual migrants. Secondly, thinking more broadly around public health and population health, and the ways in which migration might affect populations more broadly, particularly when we're thinking about delayed access or fear of accessing care, particularly for communicable diseases, but thinking about the ways in which this then can affect the populations who are living, working with different migrant groups themselves. It's thirdly about thinking about systems responses. And this is one of the things that, Sasha has spoken to very clearly about where responsibility of the state sits, but also more broadly about how can we be strengthening our systems. I was listening to the previous speaker and the end of the talk and, talking about how in universities and in training systems are we ensuring that issues around migration are embedded. And then finally, thinking about global governance. And this is often left out. And it's key to recognize there is a global movement around this. And it links to the SDGs, it links to South Africa's own health targets, to the National Health Action Plan, and per year annual targets. Without engaging with migration and continuing to leave certain populations behind, South Africa is going to struggle to meet its ambitions of various health targets, particularly by 2030. With huge implications for national health insurance, implications for increasing average life expectancy, improving our response to HIV, TB, increasingly concerns around malaria, and other emerging health needs. Now, we argue, based on the research that we've been involved in, which includes looking at policy and governance, as well as experiences on the ground and lived experiences of different migrant groups, that an effective response requires us to think of all 4 issues. And in many ways, this is no different to how a broader health system response and thinking about health system strengthening should be taking place anyway. But how do we bring in that migration lens to our work? And we talk about the need for a migration-aware approach. And this really, in some ways, is a bit how people talk about, health in all policies, for example. It's a similar idea. But how do we bring population movement into each step of our health system response, our health system design, training of healthcare workers, monitoring of healthcare responses, and really thinking about broader governance of health system structures. Now, when we talk about migration and health, many people ultimately frame it around the fact that movement can have an impact on health outcomes. For some, moving does improve their health, or it may improve their health for a short time, and for others, moving can lead to poorer health outcomes. When we're talking about forms of forced migration, such as those who are fleeing persecution or violence, we know that individuals might be coming with poorer health, and moving can sometimes lead to improvements in their health. For many others, good health is a positive selector of why people are moving. And this is as relevant to internal migration as it is cross-border. Many of these individuals, though, after moving, find themselves, sorry, this is my cat trying to eat the screen, moving themselves into contexts where their health status then decreases. So migration ultimately negatively affecting health. And in the same way, health status can determine decisions to move. We know that people tend to return to their country of origin or their place of origin if their health deteriorates. We know that many people return home. The burden is then placed on their home area healthcare systems, whether that's elsewhere in the country or in a different country. And we know that this has an impact that is often the result of the context in which someone was living and working previously. So what does it mean when somebody is thinking about, as an expecting mother, for example, thinking about maternal child health, thinking about the health of their unborn child, whilst also thinking about health of their current children? And Gloria, again, not her real name, is someone who, throughout her antenatal care experience, experienced many, many challenges, which resulted in her being very fearful of attending antenatal appointments, fearful of making bookings, and very nervous about what this would mean at the time of delivery. And these are the kind of fears that we have to better understand. Often women might be blamed for, appearing to come late for antenatal care or appearing only at the time of delivery. But often these women have struggled to retain access to these antenatal and then postnatal services. And this obviously has impact on child health when we're thinking about, for example, vaccination coverage. One of the key challenges, and I'm going to leave you to read this while I speak if you're able to, but really thinking about the fact that what we see is very competing and misapplied interpretations of policy. This comes back to Sasha's point. What we see is what the Constitution says, what we see is what the National Health Act says, but then what we see at facilities could be contrary to that, where facility managers are making decrees and decisions and placing requirements on healthcare workers and healthcare users that are contrary to the Constitution. But for those working in those spaces, this is something that's dictated by management. And because often, and all too often, it supports the negative attitudes to foreigners that some healthcare workers have, it goes unchallenged. Now, as a result, there's issues, and I think, Sasha spoke more recently about issues around access to HIV treatment. And we know that this is, these challenges are manifest now in the context of the withdrawal of USAID and PEPFAR funding. We've been doing work in Messina, and the implications of the withdrawal of these programs have been phenomenal. And I think we're not speaking about it enough, particularly when we're thinking about child health, where the children of individuals who were, as adults, receiving either PrEP or treatment through these interventions are no longer able to access that. That's having an impact on their ability to work, to earn an income, which is ultimately having an impact, particularly on food security, with impacts on children. If people are being restricted access, as the sister here from one particular clinic said, I don't actually know what happens further. So all people are seeing is denial of access and refusing access to people without really thinking about the bigger implications. What does it mean if somebody only then comes into the healthcare system in an emergency situation with a sick child that could have been prevented by going through preventative health programming and normal child health programming? Now, I don't have time to go into detail here, and you'll see the example is around sexual reproductive health rights more broadly, but I'm using this just to frame and kind of highlight the challenges and the intersecting challenges faced in this case by women when we're thinking about maternal and child health care. What I want to show you is that we sit with several levels of key challenges that are facing people. At the level of structural violence, we're talking here about policies, we're talking about restrictive legal frameworks, we're thinking about challenges accessing documentation, the backlog at the Department of Home Affairs, which also affects South Africans without documents, fear of arrest or detention and deportation, and then anti-foreigner sentiments and xenophobia making this even worse. So when we're thinking about structural violence, this is really about the challenges that are presented through the governance framing in many ways, but also about social attitudes and the ways in which the politics of policy making are increasingly driven by a xenophobic approach. which is having implications on access to healthcare. The NIHI, in its current formulation, explicitly revokes access to basic healthcare for asylum seekers and undocumented migrants, which is contrary to constitutional rights, saying that they will only have access for emergency care and for reportable health conditions. So we need to understand what this kind of structural and political debate is doing to thinking about access. We know we sit with public healthcare system challenges more broadly, and no one's denying that. So everyone in South Africa who's reliant on the public healthcare system faces various challenges. But there are additional challenges that are then faced by migrants. And the big issue here is around policy versus practice. It's around attitudes, language, documentation status, but really the increase in vigilante violence is making this far worse. And the fear of arrest, detention, and deportation now being further increased by the intervention of these vigilante groups. So what does this mean for programmatic responses? Well, we need to really be thinking about, again, what this means for everyone, but importantly, the importance of a lack of migration-aware responses. What does this mean when we think about immigration governance and people working on the development of immigration policies and their enactment versus the right to health? What does it mean when we're seeing contrary messages, where we're seeing fractures within policy regimes? And again, being pushed further by issues around xenophobia. One of the reasons this slide I wanted to share is to emphasize that when we talk about migration and we talk about migrants, yes, we're talking about foreign nationals who make up just 4% of the national population. Around 18 million people in South Africa are internal migrants, meaning they're living and working in a province different to where they were born. And we have to recognize at the moment that the healthcare system across these three areas is not able to respond efficiently to the movement of people, regardless of nationality. So this is a much bigger issue. And by putting together and recognizing that there are explicit challenges faced by non-nationals, including those without documents, by looking at a whole of system response more broadly and recognizing that this isn't about developing a parallel response solely to meet the needs of foreign nationals, it's about strengthening the health system for everyone. And this is really important because it can be misinterpreted to suggest that we're arguing for special treatment for specific services only for the use of foreign nationals. What we're saying is that you can strengthen existing healthcare system responses by bringing in issues around migration, and that's going to improve health for everyone. We are working, as South Africa also is engaged with, and South Africa actually has been quite involved in this, is the Global Action Plan that is looking at the health of refugees and migrants, which was recently extended through to 2030. And this was enacted in 2019. In 2022, the African Union, and these are really important research reports, and I'd really encourage you to engage with them because this is looking at the African Union's priorities and looking at migration as a continental challenge and looking at the ways in which we need to be strengthening systems to engage with movement across borders, which is something, particularly in Southern Africa, we have failed to do. In 22, some of you might be aware of these, and again, if you're not, I highly recommend them. And they're important resources for those involved in teaching healthcare workers and ongoing professional development, is a set of competency standards were developed through a global consultation process for healthcare workers looking at refugee and migrant health. And to go along with that is a knowledge guide and a curriculum guide. And these have been designed to be adaptable to specific contexts with certain modules or information that could be embedded into existing CPD programs, or into, for example, nursing schools, into occupational therapy courses, into medical training courses more broadly. Almost 2 years ago, at the end of 24, we saw a very important document released by the Department of Health, which is a zero draft policy advisory on refugees, migration, health and development in South Africa. The department prepared this for the National Planning Commission as a way of recognizing the importance of thinking about movement, migration more broadly, as well as refugees in achieving South Africa's global health ambitions. One of the most important steps in achieving South Africa's UHC objectives is addressing health disparities for migrants and refugees. South Africa can create a healthcare system that is resilient, inclusive, and sensitive to the needs of all citizens, including migrants, by implementing policies that address workforce distribution, healthcare access, and resource allocation. Adopting these recommendations will increase South Africa's commitment to social justice and equity in healthcare, assist sustainable development, and be in line with national priorities. The reason I took the time to read that is it's one of the first times we've seen from the Department of Health and across the national government more broadly an acknowledgement of the importance of engaging with migration when we're thinking about health. And I urge you all to think about how in our work in South Africa we can continue pushing this and take advantage strategically of the fact that the department is moving to support this. And this has been reflected in work in the past sort of 18 months with the World Health Organization, where South Africa has been involved, a partnership between WHO and the Department of Health to undertake an assessment of the health system response to migration, displacement, and health, as well as undertaking a national research agenda setting process. That's going to be released. There's going to be reports coming out in the next month or so. And these are really helpful for those of us who are involved in research to really think about what has been defined at a national level as key priorities in this field, but importantly, what this means for all of us in our work moving forward. So it's not all bad news. Here, another Congolese family, Patrick, which isn't his real name, with his son, Don Ciel, also not his real name. They had a very different experience working with outreach caregivers from one of the local NGOs who supported them and the family along every step of their way through their antenatal care, through to their postpartum care, through child health, introduction to the systems. And the importance of those individuals who were working with and accompanying individuals to healthcare systems made all the difference. But we shouldn't be in a situation where a foreign national or anyone in South Africa requires personal assistance to ensure that their rights are upheld. So I will leave you just to say, please, when this is available, make use of it. And Sasha and Section 27 continue to do fantastic work. So yeah, thank you. Sorry if I went a bit over time.
No, Jo, perfectly on time. So thank you very much. Sasha, can I invite you to put on your camera and the microphone on, and we'll now have the panel discussion. There were some Q&A questions from the previous sessions that haven't been answered. One of them was addressed to Professor Armstrong, the other one to me. I'll answer that one certainly. But let's get on to the discussion of this section. So Jo, again, I think you've given us a little bit of hope after the kind of desperate situation raised by Sasha, where you've actually identified mechanisms and you've actually described policy changes that, or at least documents that are suggesting something more positive might arise. So let me start off. As I said, I'm going to invite anyone who wants to talk to actually just put up your hand. You go to the more button and it says there at the bottom, raise hand, and we'll allow you to talk because I'm happy to take direct inputs. But let me start off by a question that was in the Q&A that was by Anonymous that was subsequently withdrawn. And perhaps I'll start off by directing this to you, Sasha. So the comment was related to the situation after the Gauteng court ruling. So I think this Anonymous is based in another province, and the problem he or she is encountering is that the provinces are saying that what was determined in the Gauteng court doesn't apply to them. So that was the one issue. But perhaps before you respond to that specifically, let us be clear about what the Gauteng ruling said, because I think both you and Jo have mentioned about constitutional rights. But what are these constitutional rights related to mothers and children? Perhaps you can be clear about that and what the courts actually allow. And then Anonymous, so that would be helpful then to reflect on whether a Gauteng High Court ruling applies to other provinces. And then I think the other point that the Anonymous raised was then what can be charged to these patients, and if they can't pay, how do you deal with that? And I think that's a more difficult question. But perhaps start off with that. Let's start off with that discussion. And Jo, I'll bring you in after Sasha has responded.
Thanks, Haroon. So the question wasn't withdrawn. I answered it, and so it's moved across to the answered section. But just briefly,
Okay,
the
great. Thank
the
you.
the Gauteng case was against Gauteng government as well as the minister, and it dealt specifically with the Gauteng policy. But what's important is that it said that the Gauteng policy is unlawful because it is contrary to what the National Health Act says. And what the National Health Act says is that pregnant and lactating women and children under the age of 6 are entitled to free healthcare services, not just at clinics, but also at hospitals, unless they are covered by medical aid. That's my kind of summary of it. So really, it's not the case that every other province can start acting contrary to the National Health Act because the case wasn't heard in their province. The National Health Act continues to apply in other provinces. So if there is a practice that goes against the National Health Act, that is problematic. And I've given my email address to that to the person who asked the question so that we can see if we can assist. Of course, there are user fees that are charged for various types of patient, but I think what's important is this very particular carve out for pregnant and lactating women and children under the age of 6 that really give them PHC and
All right. I don't know whether it's my internet. Jo, are you still there?
Sorry about that. I just got kicked off for some reason.
Continue.
Um, yeah, so the National Health Act gives that category of person very particular um, protection, and of course that stems from the Constitution, but really the key provision is in Section 4 of the NHA. I hope that answered the question that you were going to, Haroon.
So that answers it. So let me just take then, what's the situation with the 7-year-old? What are their rights? What are his or her rights?
Yeah, so someone who's above 6. Sorry, I think my internet's a bit bad, which is why I keep interrupting you. Apologies. Somebody who's over 6, if they're an asylum seeker, a refugee, or an undocumented person from a SADC state, they're entitled to be treated the same way as South Africans, which means they get means tested for anything above PHC level. What often happens is that they don't get means tested. They just get told you're foreign and you don't qualify. But that is also contrary to the law.
Okay. Thanks. So that makes it very clear. Jo, I don't know if you want to add anything to this scenario.
No, just to second Sasha, and I think this is one of the reasons with the NHI. I think there's a lot of concern. I mean, there's been concern for a long time, but greater concern about this causing even more confusion, because the NHI is specifically saying that certain groups will be excluded, which is contrary to the current constitutional right to healthcare, which is contrary to the National Health Act in its current form. So we've got, again, this policy divergence, which is causing even more confusions. And I think this is something we need to be really aware of. And it's outlined, as Sasha was saying, around means testing. It's all outlined in the Schedule H. I don't remember which schedule it is, but it's all outlined in there. And we see people using these guidelines incorrectly. And that's something that is creating far more work for healthcare providers and the work that needs to be done in healthcare systems, as well as preventing access. And I think sometimes we're not looking at just how much more work healthcare workers and people in the health system create for themselves by not operationalizing legislation, policy, and guidelines that exist. They actually make things far more complicated.
Okay, thanks. All right, so let's deal now with the issue that I think Nontando in her note makes raises an interesting point. So her comment, and I'll read it, is, since Dudula, the workload at primary healthcare facilities has decreased much. How do we convince healthcare workers not to collaborate with Dudula, even when it benefits them and locals? And I think, Sasha, you raised this point as well, that the health workers' response is a mixed bag. There are obviously health workers who believe that this is the right action. They genuinely believe that migrants should not access any of these facilities. So this is not really a question, perhaps it's a question for all of us. It's not directed specifically to you, but you deal with this all the time. Have you got some guidance on what health workers who believe that the Constitution should be should apply? How do you deal with the situation? What's the kind of advice? Again, Sasha, yourself, and then Jo. What kind of advice, or how do we deal with co-workers who don't believe the argument?
Yeah, I think this Nontando raises such an interesting and very difficult question, as you say. And we've seen it in, obviously this is not the case in all facilities, but it's the case in facilities where there are a lot of migrants who access that facility. And then Dudula prevents migrants and anyone else who's undocumented. And as I think Laurie says above, 80% of undocumented children in schools are South African, not migrants. So there are a lot of undocumented people who are also South African, but it certainly helps when there's somebody blocking a chunk of people. It reduces your workload, and so of course there are some health workers who are in favor. I think there's two main things that we need to focus on in this argument. The first is the rights question and the obligations on health workers when it comes to rights and the fact that people have rights, and it's really not for you to decide who should be able to access services and who shouldn't. And the reason that your health facility is full and that you are overstretched is not the 3 to 4% of the population that's foreign, but it's actually the fact that our health budget has decreased in real terms every year for the last 5 years, except for this year. And we have this enormous theft of resources out of the health system. Look at Tembisa, look at other things. So the problem is not the migrants, and the cause of the lack of equipment and the overwork is not migrants. Difficult to convince people when they're experiencing it in a different way, but I think that is true. And the second, of course, what everybody knows is the public health impacts and the fact that if we are failing to provide access to ARVs, to TB medication, to vaccines, to maternal, or not so much to maternal health, that just knocks our great success in improving maternal, in decreasing maternal deaths. But in so many respects, this is a public health concern. And so I suppose those are the two arguments that I would use to appeal to health workers who may be inclined to celebrate Operation Dudula's gains, recognizing that it can be a tough argument to have.
So, Sasha, let me raise an issue that you've raised, because this is controversial. You've suggested the figure is about 3 to 4% of the health services is migrants. Now, obviously, it depends in which province you are, and it would differ. But I've heard arguments, I mean, certainly in Gauteng, there are hospitals that will claim that 30 to 40% of their, say, pregnant women coming through are migrants. And even the minister has often quoted much higher figures. Do we have any real sense of what the real figures are, and where's your 3 and 4% coming from?
So I think Jo's better placed to answer this because she's done a lot of work assessing what the truth is, trying to disaggregate it from the 7 out of 10 women that is often the number quoted when the minister or somebody else goes to a particular hospital, or the X percentage. So maybe if I can hand over to Jo for a good answer on that.
I mean, this is one of the huge challenges we face when we're talking anything to do with immigration, whether we're talking about border management, immigration control, as some would say, whether we're talking about access to public services. So Stats SA, as the government statistical agency, not only through census data, but also through the continuous sort of population surveys, the quarterly labor force surveys and so forth, their estimate is 3 to 4%. And this, as a percentage of a national population being foreign born, reflects global trends. South Africa is no exception, and actually, compared to many other countries on the continent, has a far lower number of refugees and asylum seekers than is often assumed. As you mentioned, Haroon, the distribution of that population is not equal. So we don't look at 3% to 4% across each province or across each metro. We see this population group distributed very differently. And what we tend to see are those locations where we might have a higher density of foreign nationals, being used as a representative for what's happening nationally. And these are the places that the media absolutely love. These are the places that the politicians love. And it's where we see poor data, because actually we don't capture information on nationality or documentation status. So these numbers themselves are also hugely problematic because we don't actually have that data. And there's a real tension at the moment. I saw some questions around this about, on the one hand, we should be collecting information to allow us to plan our systems better. But equally, the fear in South Africa is that collecting information about people's nationality or documentation status is about surveillance. And at the moment, there is zero guarantee that information collected by the Department of Health would be kept separate to information that the Department of Home Affairs has access to. And we've seen that at the moment around biometrics that are being used, fingerprints, for example, in trying to identify unidentified corpses in morgues, where we're actually seeing the blurring of the DHA's database and that of health systems. And there's increasing call for these biometrics to be used in the healthcare system. This is very concerning, but we know we need better data. When we talk about strengthening healthcare systems, we know health information systems are one of the biggest points there, and South Africa is investing heavily in that. And I know that one of the things that the department is looking at is about how do we efficiently, for good, collect information around this, and not in a way that is then further stigmatizing access. And I just wanted to comment, sort of linked to that, I think it was coming back to Nontando's point, is we've got to recognize that Dudula isn't simply preventing foreign nationals from accessing care. It's creating spaces that nobody wants to be in. So you can be a citizen, your child can be a citizen, but actually, do I want to go through a blockade of people who are being violent, who are causing harm, and who are turning away South Africans? So when we're looking at lower use and uptake of services, we need to see that as a problem and not see it as a benefit. We need to recognize that this means there are people not in the healthcare system, not accessing care, and we need to apply population health principles. So again, you can have your own personal feelings about foreign nationals, but from a public health perspective, by refusing and denying access, we are not helping ourselves. And I think when we look at COVID and access to vaccines, this was one of the first times that I think at a national level, there was a recognition of the importance of including foreign nationals, including undocumented migrants in the vaccination program. Everybody could understand that. There's no point in me being vaccinated if others can't be. But we've fallen away from that and we've forgotten this. And I think that when we're looking, we need to, on the one hand, continue our rights-based work. There is no question other than that being central. But I think for those of us who are working in healthcare systems, who are working in very politically different, difficult and tense spaces, we need to go back to public health and population health principles around why the importance of ensuring everyone has access to care is critical, and really doing our best to try and ensure that that is what's guiding policy making and not something that we're seeing at the moment, which is anti-foreigner sentiment being behind the politics of policy making.
All right, I see we've reached our time limit. So both to you, Jo, and to Sasha, thank you very much for an excellent enunciation of what the situation is, what the Constitution says, what the law says, what policy says, and where policies sometimes are wrong. I think I'm trying to think how I'm leaving the session. I think, Sasha, was it Ruth who said she almost cried after your presentation? And I think from giving us many of the examples, it really brings home the situation, and it makes me feel worse about the situation than better, because it seems like the crisis is deepening. You've raised the issue of the impending court case, but this fear that the current movement is beyond the current movements are going beyond the law. And what you've called for is better governance. And I suppose we all look for hope in that it's a governance issue. It's the role of government to primarily deal with it. We ourselves as health workers obviously can contribute to the problem, but we're also part of the solution because we have co-workers who might be fueling the problem. And Jo, I think you gave us the broader view that you offered about the situation of migration, I think was very helpful as well in us understanding what the broader dynamics are. So to both of you, thank you very much for making yourself available for this. I certainly, and I'm sure most of our members leave the session much clearer about not necessarily recognizing solutions, but certainly recognizing perhaps what the right thing could be and how they could make the case for the right thing. So thank you very much to both of you. Much appreciated.
Thank you.
Thanks.
Okay, so at this stage, I'm going to hand over to Uta, because I am sorry, Uta, I've gone 5 minutes over the time limit, but I trust we've got enough space to say the things we need to at our AGM.